Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up sessions, and this particular session will be on pediatric TB, looking at the treatment and prophylaxis. So I want to do a quick slide just on the case definitions, because where children are concerned, the case definition is actually going to have an impact on your treatment. So remember that TB is a reportable disease, and let's just go through a few of the case definitions. Now, these are usually filled in by the nurses, but if you as a doctor has made the diagnosis, you might have to advise the nurse in terms of the classification. So firstly, we're going to define whether the site of infection, whether it's pulmonary TB or extrapulmonary TB. And pulmonary TB is only if the actual lung tissue is affected. So if there are lung damage, or if we have proof of bacilli, that will be pulmonary TB on sputum. So for example, if a child has only got hilar lymphadenopathy, the lung fields are completely clear, that will actually be a case of extrapulmonary TB, as would, for example, be a pleural effusion. If a patient has got pulmonary TB, they will then be diagnosed, or they will be classified according to their gene expert result and their AFB result. So remember, all patients who are gene expert positive, when we are diagnosing them, all have to have a baseline AFB done for monitoring. So if they're gene expert positive and the AFBs also come back positive, that will be a gene expert positive, smear positive patient. If the AFBs come back negative, that will be a gene expert positive, smear negative. As much as possible, we want to avoid having a baseline classification where the gene expert was positive but a smear not done. And then with children, it's very important that we also classify according to the severity of the disease, complicated or non-complicated, because it's going to change the treatment regime that we're going to use. And we'll talk more about that when we look at the regimes. And then very important is to also note on whether this is a new case or whether this is a retreatment, so a child who's had TB treatment in the past. So let's go a little bit more into the actual treatment. So TB treatment is the same mostly in both HIV infected and HIV uninfected children, but we'll go into a little bit more detail there. And basically our treatment comprises of two phases. So an intensive phase of 2 months with either 3 or 4 drugs, and then a continuation phase of 4 months with 2 drugs. So it's very similar to the adults. If you have a very severe or complicated TB disease, the treatment may be given for a longer time, and we usually do that by prolonging the continuation phase to 7 months, and that will usually happen under a pediatrician or a consultant's advice. Now with children, the drug dosages depend on the body weight of the child and must be adjusted as the weight changes, and often we would expect the weight to change, not only because the child is growing, but also because the child is recovering the weight loss that they might have had during the time that the TB was not yet diagnosed. So let's look a little bit more at these different levels of TB that we have in children. So in adult, all adults will get 4 drugs in the initiation phase. But in children, we differentiate between uncomplicated and complicated TB. So uncomplicated, we usually expect to be smear negative TB and your less severe forms of extrapulmonary TB. So that's particularly that lymphadenopathy that I mentioned earlier. And we treat those with 3 drugs, INH, rifampicin, and PZA for their initial phase, and then 2 drugs, just the rifampicin and INH in the continuation phase. But if you have a child that has got smear positive pulmonary TB or cavitary TB, so the kind of TB we also expect to see in adults, then we will use the 4 drugs, the INH, rifampicin, ethambutol, and PZA in the intensive phase, and then our normal 2 drugs in the continuation phase. Also note in very severe TB, so children who are very ill or malnourished, very low CD4 counts, your TB meningitis, TB bone, TB abdomen, and especially miliary TB, you may decide to treat with 4 drugs and to prolong the intensive phase of that treatment, but these children must be consulted with an expert. So let's just look here, for example, at some of our TB treatment charts. They are banded according to weight, and the latest charts can be found in your EDL. There's also a link in the notes section below for an actual TB drug chart that's easily to print. The uncomplicated TB, remember, we do not use ethambutol, mainly because of a concern that there is a very small risk, but a risk nevertheless, of possible visual disturbances which won't be picked up very easily in a small child. And therefore we use the 3 drugs in the intensive phase. One of the big challenges with TB treatment in children is that we do not have very easy and palatable formulations that we can prescribe. So you can see they're all there in tablet form, which is a real challenge. You may find PZA in liquid form, or you may have to actually create your own liquid. So you'll see there's recommendation for PZA. You can dissolve the 150 milligram dispersible tablet in 3 ml of water to prepare a concentration of 50 milligrams per ml, and then you can use those body weight recommendations. Please note, obviously, you're only going to either use the PZA 150 milligram or you're going to use the broken tablets if you only have the 500 milligram formulation. And here's our chart for complicated TB. So in this case, we have added in the use of ethambutol. The ethambutol 400 milligram tablet is quite a complicated tablet to give. So each dose you have to actually crush the 400 milligrams to a fine powder, and then you dissolve that in 8 ml of water so that you have a concentration of 400 milligrams per 8 ml. And you're going to discard any of that solution that you're not actually using. And then again, you will use the milliliters as per this dosing chart. There's a specific dosing chart for treating TB meningitis and miliary TB. And in this case, we actually use a higher dose of milligram per kilogram, and we are using ethionamide instead of ethambutol because of its better penetration of the blood-brain barrier. In TB meningitis, we use actually quite high dosages of prednisone, 2 to 4 milligrams per kilograms per day. I would discuss any of these cases with a consultant before starting them on treatment. We also want to note an important difference between the South Africa and WHO guidelines regarding the TB treatment and HIV. So in the South African guidelines, we use exactly the same chart whether the child is HIV positive or whether the child is HIV negative. So if you've got a complicated case, complicated extrapulmonary TB, or you've got smear positive cases, then you're going to use your 4 drugs in your intensive phase. But they also don't use, they use the 3 drugs in the uncomplicated cases. But the WHO recommends that HIV infection automatically makes it complicated, and they therefore use all 4 drugs in all children who are HIV and TB co-infected. So as I said earlier, the concern has always been ethambutol, and apparently ethambutol is considered actually very safe in young children. It's mostly to do with the dosing that might affect the vision. And dosing, use of dosing is quite complicated in children under 4 kilograms, so you will discuss those with a consultant. And as long as we keep that ethambutol dose as low as possible, less than 25 milligrams of kilograms, it's not a very great concern. The bottom line is if the child is clinically ill, you're probably going to use the 4 drugs in that first 2 months. But if you have a child who's HIV positive, it's got a high CD4 count, and they've got only a hyaline-lymphadenopathy, you may consider just using the 3 drugs, just in terms of simplifying the drug regimens in the first 2 months. There's always a concern about using steroids in children with TB and HIV. The evidence is that we underuse steroids and that there might be more cases where steroids could have been useful and should have been used. Certainly, the main indication for using steroids in children with TB is TB meningitis. They've developed very high pressures. It's very important to manage that inflammation effectively from early on. TB pericarditis also usually qualifies automatically for additional steroid treatment. And children where you have a mediastinal lymph node that's actually obstructing the airway. So you would actually hear a very strong whistle on the chest, or you might even see the child struggling because the lymph nodes are obstructing those vessels. Severely ill children with disseminated TB, miliary TB, you may want to consider steroids, again under advice. And the same with iris. Depending on how severe the iris is, it may be useful. Important is that you have to use a decent dose. So the minimum dose of the prednisone is 1 to 2 milligrams per kilogram. But as we've seen earlier with TB meningitis, you can use as much as 2 to 4 milligrams per kilogram. And that's partly because the rifampicin is actually already reducing the actual active dose of that prednisone. And we normally add it for about 4 to 6 weeks, and you will do this under consultation. In children, it becomes much more complicated to then monitor the response to the TB treatment, as we don't often have AFBs at the beginning to help us even with the diagnosis. So younger children especially must be reviewed at least monthly or possibly even more regularly for the first 3 months of treatment. And the biggest thing you're going to look at is you're going to see what the weight is doing. If the child's on the right treatment, you would expect that weight to start picking up dramatically. And you're going to look at resolution of the symptoms. In older children, we can use our smears, our AFBs, the same as we do with adults to follow up at 2 and 5 months of treatment. X-rays is not particularly helpful as resolution is slow, and particularly the lymphadenopathy. You may have successfully treated the TB, but the high lymphadenopathy might not settle down, and that is the same for example, lymphadenopathy supraclavicular. Those may not necessarily settle very quickly. It doesn't mean that the TB has not been treated. And again, you're going to use your weight to help you monitor those children. If the child is not responding to treatment, we're really going to need to investigate further. Most common cause still of not responding to treatment is adherence, so that you want to check first. But you need to first make sure, is this perhaps resistant to TB, or do I actually have the right diagnosis? So if you haven't had bacterial confirmation, you might be dealing with Mycobacterium avium complex, and you might be dealing with something that's not TB at all. It might be a lymphoma, and you need to go back to the drawing board. So similar as in our adults, if you are able to get sputum and a child is AFB positive, for example, those children at 2 or 6 months that are still AFB positive, we will do a line probe assay on those children to check for both the INH and RIF resistance. So let's look a little bit at TB treatment and ARVs. Firstly, very important, as we've outlined in the other presentations, all pediatric TB cases must have an HIV test done. And we can start out at about 2 to 8 weeks after TB treatment initiation. We give it about 2 weeks to settle. Then adults, there was a very clear study where they use a CD4 of 50 to help decide on whether you wait the full 8 weeks or whether you start earlier. So in adults, if the CD4 is under 50, you must start at 2 weeks. If the CD4 is over 50, you can delay until the patient is settled on their TB treatment. In children, that recommendation is not as clear, but the general rule applies. If a child is very ill, you may want to start your ARVs earlier. If a child, however, is relatively stable and is quite well, it may be very useful to wait with that ARVs until the full first intensive phase is finished to reduce the risk of iris and to also just make the drugs a little bit less complicated. So as with the adults, you're going to watch for iris, especially those children with the low CD4 counts. Probably the most important thing we have to remember with TB treatment and ART in children is that many of our littlies are on Kaletra or lopinavir ritonavir. And unfortunately, the rifampicin reduces that dose of that lopinavir in the blood by as much as 90%. So it has a dramatic effect on the ARVs. So we therefore have to boost that Kaletra. The ideal way of boosting the Kaletra in children is to add extra ritonavir according to the dosing and the ARV dosing chart. There's a special column of how much ritonavir you need to add in. If you did not have any ritonavir, as a very, very last resort and for short periods of time, you could double the dose of the Kaletra. But studies have shown that this is simply not good enough. And a lot of these children can develop resistance to their lopinavir ritonavir. Our ARV guidelines recommend the use of Kaletra on all children under 3 years old or 10 kilograms. And you can start using efavirenz once the child is over 3 years and 10 kilograms when you initiate the child. If you start a small child on a back of a 3TC and Kaletra, they will stay on that regimen throughout. And then we've already mentioned the very importance of boosting the Kaletra. One first option, adding ritonavir, and as we've said, the double dose of Kaletra is not nearly as good, and you only want to do that if you, for some reason, cannot get hold of ritonavir at all. So now we've spoken a little bit about TB treatment, so let's go back to that case we discussed in the second presentation, a little girl called Susie. And at that stage, we had to decide whether we were going to start ARV treatment. And this slide just reminds us of why we were considering TB treatment in this little girl in the first place. And on the yes side, she was a high-risk age. She was 5 months old. She had a history of recurrent lower respiratory tract infections. She'd had various bits of antibiotics in the past. And most worryingly, she was not growing well. She was not picking up weight. The x-ray showed some hilar lymphadenopathy, and she was HIV positive, which also put her at a very high risk. The concern was that her PPD test, her TST, was negative, although that's quite common in a very low CD4 count. The gastric washing was also negative, so we had no bacterial confirmation of TB. Probably the one that was the most worrying is that there was no actual known TB contact that we could get through the history. But because of her very high risk, her age, as well as being HIV positive, on balance, it was decided that we would want to start her on TB treatment. So here's some of the things we need to consider. So firstly, what is Susie's classification? Remember, we said that's going to make a difference in terms of the treatment we may use. And classification is different than diagnosis. So, for example, we can classify using our IMCI, and we can also classify as we do when we report to the DOH. According to IMCI, Susie will be called a probable TB because she has various symptoms of TB, but we do not have confirmation of that contact. But we would call this uncomplicated TB from a case definition point of view because there's only hilar lymphadenopathy. And as I mentioned earlier, under the WHO guidelines, they might say because she's HIV positive, they would automatically call that a complicated TB. It will depend on how sick the child is, which will help you make that differentiation. So in this particular case, she's got HIV, but she has a very low CD4 count of 5%. She's repeatedly ill. She's not growing well. So we are concerned about this little girl. So what are we going to do for her TB treatment? So in this case, we therefore decided to use all 4 drugs in that first 2 months. We added in ethambutol because of that very low CD4 count and because she was so unwell. And then she would have RH for 4 months after that. So that's rifampicin and INH. How soon would you start the ARV? So again, her CD4 count is very low at 5%. It's under 15%. And we would therefore start the ARVs very quickly within 2 weeks after starting TB treatment. Which ARVs would we give? She's 5 months old. We're going to use abacavir, 3-TC, lopinavir, ritonavir, and we're going to give her some extra boosted ritonavir. So under this treatment section, we have to talk about prophylaxis, which will include post-exposure INH use in children to help prevent TB. And there's been very clear guidelines in terms of the use of INH in adults, but we're still struggling to come up with a good plan for our children. This is the algorithm that we use for documented TB exposure. I'm not going to talk about the right-hand section. I want to talk about the left-hand section where we have a patient who's got no current symptoms or signs. So in the current guideline, if that child is less than 5 years old or is HIV infected, then we're going to give that child INH for 6 months, and we're going to keep a very close eye on them to see whether they're going to develop TB. So note, this is children who have known TB exposure or known TB contact, and we will give the INH every single time they are exposed. If they're more than 5 years old and they do not have HIV, then we will screen the child for TB, but there's no need to give INH because those children, even if they have developed a TB infection, there's actually a very low risk of that TB infection progressing into TB disease, especially within that first 6 months. So let's just go through this again in summary because this is very important. So any child is under the age of 5 or any child who's HIV infected, doesn't matter what their age is, if they've had a TB contact with an infectious disease, case of drug susceptible TB, you were going to give that child INH for 6 months. If you have children who are HIV negative, under the age of 5, and you discover they have a positive MAN2 for whatever reason, you've been investigating them maybe for something else, that shows that that child has been exposed to TB and will also qualify for INH. And similarly with HIV infected children, if you also discover they're MAN2 positive, that could be an indication for INH. Now, I need a small caution here. Do remember that if children had TB in the past, then that might mean why the MAN2 is positive at the moment. So you will also have to take a careful history, and then depending on that. Also important is that every single exposure in your children under 5 or your HIV infected children, you will again give the 6 months of INH. MDR TB contact is to be referred or discussed with an expert pediatrician, and I've got a little slide later on that just shows what the current practice is in the Eastern Cape. But there's still a lot of research being done around IPT in children, and there's a new recommendation that's come out recently through the WHO that we've had to consider in South Africa but have not adopted at the present time. A rather little busy slide there, but basically what it was saying is that children with HIV who are older than a year old, even if they've not had a TB contact, should be offered 6 months of IPT as part of their normal TB package. So you would diagnose a child over a year old with HIV, you would automatically give them INH for 6 months. However, in South Africa, there's been no benefit of that use of IPT in HIV-infected children with no history of TB contact. And so that is not current practice. So at the moment, we do not use pre-exposure INH. We only use exposure and IPT once we know a child has had a TB contact. We're well aware that we normally use INH for 6 months in our drug-sensitive TB children. The challenge is those children who come in with a drug-resistant TB contact. So it's very important if you've got a child where, for example, the mother or the contact person are known to have MDR or monoresistance TB, you're still going to investigate that child in the same way to try and make a diagnosis of TB or exclude TB. But very, very important to try and get as much information about this contact. So are they smear positive or not? Exactly what is their sputum results? And what particular regimen is that contact taking at the moment? So this is at the moment best practice that we are using in the Eastern Cape under Dr. Lochin at Frere Hospital. Please do discuss if you see contacts, children contacts to people with DRTB. So if we've got patients where the contact was an isoniazide monoresistance, we would actually use rifampicin in those children, 15 milligrams per kilo. If the contact has been diagnosed with rifampicin monoresistance, we use isoniazide, 10 milligrams per kilograms as per usual. And for MDR TB, we actually give 3 drugs. So we are using high-dose isoniazide, ethambutol, and levofloxacin for a 6-month period. And of course, those children will be regularly followed up. But very importantly, you are not going to prescribe these without backup from your pediatrician. The management of a child who's had an XDR TB contact is very complicated. They're going to need close follow-up. We're going to need to find other ways to also reduce the risk of exposure to this child. But all of those cases you are going to be discussing with a specialist pediatrician or with your local TB hospital. So let's just look a little bit at a neonatal TB prophylaxis and look at a typical case. So we've got Simpiwe's mom, Dorothy, was diagnosed with TB in her last month of pregnancy. She's HIV positive and she received ART for 2 months prior to his birth. Her TB was diagnosed, she had a cough for 2 weeks and she had night sweats, and her gene export result was positive, sensitive to rifampicin, and she was started on TB treatment. It might even have been a TB iris because she had been started on ARVs recently. So how are we now going to manage Simpiwe at the birth and beyond? There's a challenge around clear guidelines for neonatal prophylaxis, as there seems to be different regimens outlined in different documents. Please note that the recommendations in the Pediatric TB guidelines, as well in the National TB guidelines in the body, is incorrect. There's a correct algorithm in the back of the National TB guidelines. Probably the best place to get your information is in the EDL. There's also different debates on what do we define as TB during pregnancy. Some people died. The highest risk is certainly the mother who was diagnosed in the last 2 months of pregnancy, or has failed to convert to smear negative, or has no documented smear conversion during her pregnancy on TB treatment. And in those children, we would not give any BCG at birth. The child will need TB treatment if we cannot exclude TB. So you're going to examine that child very well to check whether there's any TB. And then we need to prescribe INH for 6 months if TB is excluded. But I would discuss any mom who had TB treatment during a pregnancy with the pediatrician and make sure that to follow up those children very closely. This is out of the EDL and shows that all asymptomatic neonates receive isoniazid for 10 milligrams per kilogram per dose once daily for 6 months following the birth, obviously after we've excluded TB. And when do we then give the BCG? That usually happens after the IPT is completed and if the patient is asymptomatic. And in South Africa, we usually say if they're HIV positive, we will not be giving BCG at any time. Although there are some pediatricians that would recommend to give the BCG if the child is stable on ARV and has a normal CD4 count. I would discuss any of these children before considering giving BCG. If your mom has TB, it's very important to still continue with the breastfeeding because the benefits will vastly outweigh the risks. If the mom is not yet seroconverted, you can advise her to use a mask whilst breastfeeding and actually provide her with masks. And again, we want the HIV-infected mom to be encouraged to breastfeed exclusively or formula feed exclusively in line with the national guidelines for first 6 months. Just a note that the TB drug concentrations are actually too low to protect the infant from TB or to be toxic to the baby. Although there's a little bit in the breast milk, it's actually insignificant amounts. So lastly, a few key points. Our control of TB is a nationwide priority, and advocating for TB infection control both in the workplace and at home is important parts of helping us to bring this TB epidemic under control and bring more protection also for our children. Very important, the screening for TB at every medical encounter of our children. We're good with the adults, but not so good with the kids. And we need a very high index of suspicion to diagnose TB disease in children, because our investigations just not help us to get a definite diagnosis. The most important aspect in this presentation is to remember to add ritonavir boosting if the child is on lopinavir ritonavir as part of their ARV regimen. Thank you very much. Please do see our first 2 modules, 3A and 3C, on the background of TB in children and specifically the module on the diagnosis of TB in children.